Smart Africa is being implemented on the ground in 3 countries, but also learning from 1/4 country. So we are implementing in Uganda, we are implementing in Ghana, we are implementing in Kenya. In Uganda, Uganda is the scale-up site, and then Kenya and Ghana are what we call the capacity building sites. So we will have panels from each of these sites, but what we are going to begin with, we are going to begin with a panel from Uganda that is going to take us through their learning, implementing the intervention associated with Smart Africa, which is around multiple family groups. As you heard from Dr. Joshua Gordon and also Patel Arya, the whole concept around task shifting. And so I want to invite Josephine, I want to invite William Byansi, I want to invite Rachel, Dr. Yesim, and I thought Joshua Kiyingi also. So what they are going to do is to take us through, we have 1 hour. So they are going to present for about 35 minutes, and then they will engage in a question and answer session with the audience. So each of these is a very well accomplished scholar. William Byansi is a doctoral student, actually a doctoral candidate. He's defending his dissertation in a week's time or a couple of weeks from now. Rachel is a postdoc with a PhD from the London School, and she works as a postdoc here at ICHAD and Smart Africa. So she will tell us, the findings that she has analyzed from the data. Josephine is our Smart Africa study coordinator in Uganda, who is also an incoming PhD student here at Washington University. Joshua Kiyingi is a PhD student here at Washington University, who is an economist, but also is one of our former data analysts for Smart Africa, but also coordinator. And Yesim, who is Dr. Yesim Tozan, is a professor at NYU, New York University. She does all the costing for us and the cost effectiveness components of Smart Africa. So you are all welcome. You can read the details of these well-accomplished presenters online. So I won't go in details about each of them, but they have a long list of accomplishments. So William, I pass this on to you.
Okay, thank you. Thank you, Dr. Fred. Good morning, good afternoon, good evening, everyone, wherever you are. My name is Joshua Kiyingi. I'm a first-year Public Health Sciences doctoral student at the Brown School, Washington University in St. Louis. I'm privileged to be part of the Smart Africa study as a study coordinator. William, next slide. Yeah, Smart Africa is funded by the National Institute of Mental Health, and we have collaborators across the African continent as well as the USA. On the African continent, our collaborators are in Uganda, Ghana, Kenya, and South Africa. In Africa, there is a high prevalence of disruptive behavior disorders, especially among children, yet we have a huge gap in the mental health services. Therefore, there is a need for effective and scalable solutions that recognize the challenges that are unique to Sub-Saharan Africa. Therefore, Smart Africa's overall goal is to meet the significant child mental health needs of children in Sub-Saharan Africa, as well as close the serious services gap. Smart Africa has 4 aims. One is to establish and engage a transdisciplinary research consortium. 2 is to build a child mental health implementation research capacity. 3 is to conduct evidence-based practices scale-up research study, which is being implemented in Uganda. And 4 is to disseminate timely and programmatic findings. Next slide. Next slide, William. Let me continue. The way Smart Africa studies are designed, this is a randomized control trial with 3 study arms. One of the study arms receives the usual care, which is the comparison group, and the other 2 study arms receive the multiple family group intervention. For those 2 arms which receive the multiple family group intervention, in one arm, the intervention is delivered by peer parents. These are parents, but they are drawn from local school planning councils. And in the other group, the intervention is delivered by community health workers. The community health workers are drawn from primary care clinics. In Uganda, the study is implemented across 30 schools, and each arm has a total of 10 schools. We targeted to recruit a total of 3,000 children across the 3 arms. That is 1,000 children per each arm. Next slide, William. As you can see from the screen, amidst COVID-19, we continued implementing the research study. We developed a risk management plan, which was approved by our local IRB. We also restructured our offices to make sure there is social distancing when people are working. But we also moved away from face-to-face interviews when we are collecting data to telephone interviews. We have been using telephonic interviews to collect data ever since COVID-19 started, and this has really worked well for us. Thank you. I will invite William Byansi to take it from here. Thank you.
Thank you so much, Joshua, and good morning, good afternoon, everyone who is tuning in from around the globe. My name is William Byansi. I'm a doctoral candidate here at Washington University in St. Louis. And I'm really pleased to be here this morning and share with you some of our findings, our preliminary findings from Smart Africa Uganda. So to begin, one of the things we have done is to assess behavior challenges among children. We use the 3 measures. One of them is the Disruptive Behavior Scale and the Iowa Corner Scale. But also we have assessed for impairment associated with behavior challenges among children using the impairment rating scale. So looking at our baseline findings, one of the things we found that overall about 6% of participants in our sample, I just talked about the entire sample. This entire sample was also dyads, so we recruited the children as well as their caregivers. So the data I'm presenting here is about parent reports reporting on symptoms of children's behaviors. So we found in our data that overall about 6% of our participants evidenced symptoms for disruptive behavior disorders. Specifically, we looked at oppositional defiant disorder and a conduct disorder. So if you look at the breakdown, about again 6% of our participants evidence symptoms for ODD, which is for oppositional defiant disorder, and about 2% of our participants evidence symptoms for conduct disorders. These findings have been published in James Psychiatry if anyone is really interested in digging deeper into our findings. And this will be my last slide for this presentation, but we have also examined the association between family dynamics and behavioral challenges among the children. And I found that parental supervision, marital status, and also family size are key important factors in understanding why some children, evidence symptoms of behavior challenges and others do not. So one of the things we are looking at is understanding how these family dynamics impact parenting and how parenting subsequently impact behavior outcomes. So we are thinking that our intervention, which my colleague is going to talk about, is really, really key in helping us provide parenting tools for our caregivers and parents who really take care of children on a daily basis. So briefly, these results are under review, and that's what I wanted to talk with you about today. I will hand over to Rachel to continue with the results.
Thank you so much, William. So I just want to mention briefly about what the multiple family group intervention is. So basically, families come together in groups, to learn from each other, basically skills about parenting, how to, set rules, responsibilities, respectful communication, how to, manage their stress when parenting their children, and also how to, build social support. So as Joshua mentioned, the intervention in Uganda had, 3 arms. And what we're all curious about is to know how this intervention was, effective in reducing child behavioral outcomes among children in Uganda. So to do so, we utilized longitudinal data from the recently completed Smart Africa Uganda study, and we investigated, how the intervention impacted child behavioral outcomes among children. So we specifically looked at, the impact of the intervention at 8 weeks, which is mid-intervention, and at the end of the intervention, which is at 16 weeks. So the outcomes we looked at were oppositional defiant disorder as measured by the Iowa-Connors scale, and also total impairment as measured by the impairment rating scale. Now, in addition to looking at overall impairment, we also looked at, the 6 of the domains of the impairment rating scale separately to see how children's behavior impacted their functioning in these different areas. So in terms of the analysis, we ran, 3-level, multi-level, 3-level mixed effects models. And we ran pairwise comparisons of post-baseline means within each time point. So in terms of what we saw for oppositional defiant disorders, you can see here from this graph, the blue line represents the control group, children who are assigned to the control condition. The red represents children who are assigned to the pair-and-pairs condition. And the green line represents children who were assigned to the MFG delivered by community healthcare workers. And we can see as we are over time that the intervention is very much more effective in reducing oppositional defiant disorders among children in both interventions arms. And at 8 weeks, we saw that the children who were in the community healthcare workers were already showing significantly lower levels of oppositional defiant disorder compared to those who were in the control condition. For total impairment, we see a similar pattern. At the end of the 16-week intervention, both intervention arms, children had significantly lower levels of impaired functioning. However, at 8 weeks, only the pair-and-pairs group had lower levels of impaired functioning compared to the controls. So as I mentioned, we looked specifically at how children's behavior were affecting their relationships with their peers. So at the end of the intervention, we see that both the intervention groups, children's behavior did not significantly affect their peers, their relationships with their peers compared to the control condition. And also for siblings, we see that at the end of the 16 weeks, both intervention arms were doing significantly better than their control condition. Next slide, please. A similar relationship was observed for children's relationships with their parents. Their behaviors in the intervention arms were significantly better in that it did not affect their relationships with their parents as much as compared to the control condition. And we saw as early as 8 weeks, children in the parent-pairs condition were more likely to have better, functioning with their parents. And we also looked at, how their children's behavior affected the self-esteem. If you can go back one slide. So, yeah, so their behavior did not negatively. Children in the intervention arm had better, behavior or outcomes in that their self-esteem was better compared to the children in the the control condition. And in terms of the academic progress, we saw that at the end of the 16 weeks, both intervention arms were doing better in terms of the academic progress and also in terms of their family functioning. We see that the overall family functioning children in the intervention arms are doing significantly better than those in the controls. So as we can see, this multiple family group intervention had very positive outcomes in terms of children's relationships with their peers, their siblings, and in terms of their functioning in schools, and also in terms of their overall mental health, in terms of their self-esteem. Thank you so much. I'll turn over to my colleague Josephine to take us through the qualitative findings.
Thank you so much, Dr. Rachel, and my fellow colleagues through the previous presentations. And I'm Josephine, and I'll be taking you through the qualitative component of our study, which basically aims at testing or understanding the process and the processes of the implementation of intervention that has previously been discussed by Joshua and Dr. Rachel. And of course, I'll take you through how we selected our participants. We selected a total of 24 facilitators and 8 head teachers from 816 treatment schools, which have been highlighted earlier. And then out of this, the reports that all the findings that we are going to present today are only reflected or only reflecting 12 facilitators and 4 head teachers from the first 8 schools that we visited for the qualitative interviews. I would like to mention that these interviews basically are aimed at getting the experiences of the facilitators while delivering our intervention, which has been earlier mentioned, the multiple family group that is commonly known as Amakama Sanyufu in our local language. I would also relate to what previously Dr. Rachel has mentioned about the performance in school of our children. The head teachers have reported that there has been really an improvement in performance of our children that are in the treatment arm. If you compare children that received the intervention to those that didn't receive the intervention, there has been really a great improvement in their academic performance and behavior. Of course, we cannot fail to say yes because children spend most of their time in school, so this could be right judgment from the head teachers. Next slide, please. Of course, I will always talk about the parent and child relationships. This has also been highlighted in our preliminary results that have been read by Dr. Rachel, that there has been an improvement in the child and parent relationships. And this information, or like you see in the quotes from our facilitators, that before parents weren't really considering children's views at home. But after the intervention, there has been a bond between parents and children, like you see in the quotes. And we really appreciate the multiple family intervention for the great work that has been done to improve the parent and child relationships. Of course, if we look at the family relations, like William mentioned before, like these parent peers or facilitators have been selected from the community. So we very well know that they always have a time to meet with these parents, and actually they're always giving us feedback that they've been meeting with these families, so they know how the relationships have improved in their families. And they really reported that the family relationships have improved. There has been actually, some of them have reported to us that before the intervention, women were beat up by their husband. I mean, there was domestic violence in families. There were no rules in the families. I mean, children weren't listened for, but now after the intervention, there has been an improvement, and we cannot really fail to acknowledge the effect of the intervention because these facilitators report directly from within the community. So we appreciate the effect of the intervention in improving the family relationships. Of course, like you see, the letter that is displayed is a letter from one of our schools that was sent to Dr. Ssewamala, appreciating him for the great work that has been done through the intervention. And actually, like you read, people are still yearning for more interventions of the same because of the positive impacts that have been brought in the community of our country, Uganda. Thank you very much, and I'll turn over to Dr. Yesim.
Dr. Yesim, you are muted.
There you go. Now, thank you, Josephine. Good day, everyone. My name is Yesim Tozan. I'm an assistant professor of global health at NYU School of Global Public Health. In this project, I'm leading the economic studies related to the intervention, the MFG intervention, and we have completed the costing study. And in this presentation, I'm going to present the costing results. Next slide, please, William. All right, so evidence-based practices for prevention and treatment of child and adolescent mental health disorders exist. And however, attempts to scale them up, even in high resource settings, have faced challenges. In low and middle income countries, particularly, there's extreme shortage of mental health professionals and other resource constraints. And these impediments basically prompted calls for innovative approaches to deliver mental health services in community settings. As a result, some of these evidence-based practices have been adopted for delivery by lay healthcare workers, like community health workers, consistent with task shifting strategies. Despite the evidence, extensive evidence on the can we stay on the previous slide, William? Despite the extensive evidence on the transportability of these evidence-based practices to low resource settings, including in Sub-Saharan Africa, large-scale implementation and evaluation studies are sparse, and there are specific knowledge gaps related to uptake, integration, and scale-up of these interventions. Particularly, little evidence exists on the economic costs and cost-effectiveness of these interventions in low-resource environments. Next slide, please. So in the context of the trial of the MFG intervention in Uganda, we basically assess the economic costs of the intervention aimed at improving child behavioral health outcomes through task shifting strategies. As you have heard from the previous panelists, the intervention was delivered by community health care workers or trained parent peers. And we also costed out the control arm where the intervention, basically the control arm was the standard mental health care promotion based on the resources provided by the Ministry of Health in Uganda. Next slide, please. So as part of the trial, we have conducted a prospective micro-costing study involving over 2,500 children aged 8 and 13 years old and their caregivers. The intervention was implemented in a primary school setting in 3 different districts in southwestern Uganda. And then, as I just mentioned, we basically measured the resource use in all study arms and used a prospective approach to costing, and we had a chance to also compare the costs in the different study arms. Next slide, please. So we basically estimated the total per child costs in each study arm over the duration of the intervention, which is 48 months. As I mentioned, all the costs were collected by trained research assistants on the ground as part of the iChat team, using standard and validated cost extraction tools. The perspective of the costing analysis was the healthcare provider perspective, meaning that all the costs incurred to plan, deliver, monitor, and evaluate the intervention were included in the analysis. We conservatively based our cost estimates on the treatment on the treated, meaning actual participation, but we also present results on the intention to treat sample. We measured all donated resources and we valued them. This way, we not only considered the financial expenditures in the study budget, but at the same time, all the resources used for the delivery of the intervention. We were very careful about excluding research costs. As you can imagine, this is part of a trial. We categorized our costs as programmatic costs or research costs, and all costs were adjusted for inflation, discounted at 3% and expressed in 2008 USD dollars, which is the start year of the intervention. So resource use basically was measured for all activities. This way we ensured that we have high quality microcosting approach applied, and the major cost categories are listed over here, including personnel, identification of schools and school visits, especially in the setup phase of the intervention, screening and recruitment of study participants, provision of school lunches as part of the intervention, the bolster standard of care, mental health promotion, which is standard across all study arms, training of MFG facilitators at the beginning and their the delivery of the intervention, specifically MFG sessions at schools. As I mentioned, all the donated resources, which included teacher time, classroom space used in participating schools to deliver MFG sessions. The stakeholder and engagement and dissemination activities were specifically costed out. We also measured program overheads, including transportation, utilities, maintenance, office supplies and printing, and finally, the capital costs that these are the items that were used in the project that has a lifetime over a year. So here I present the results using intent to treat sample. You can see in this, the bottom row, the last row presents the total costs in 2018 US dollars. The control arm is per child $122. The MFG arm delivered by the parent peers, $253 per child, and the community health worker arm, $255 per child. You can see that here the personnel basically expenses were the major key driver of program costs, and that's basically a result of the training efforts for the parent peers and CHWs and the intensive supervision provided during the intervention, as well as the monitoring, evaluation, and quality assurance of the intervention. So it was quite human resource intensive intervention. On the next slide, you will see the cost estimates for the treatment of the treated sample, which means the actual participation. Here, one thing to note, this is a more conservative estimate for us, and these are the results that we would use in a future cost effectiveness analysis. You'll see the based on actual participation, the difference between the MFG PP and MFG CHW arm. What we have observed during intervention delivery, more family members participated in the MFG CHW arm, which increased the cost of family incentives, and that's where the difference comes from, and we see lower participation in the parent peer arm, which increased the costs a little bit. Next slide, please. Like every study, there are certain limitations and strengths. Let me start with the strengths. The first, to the best of our knowledge, this is the first microcosting analysis of an evidence-based MFG intervention in a low-resource environment. So we contributed to the existing literature on the costs of this intervention in low and middle income country setting. We were fortunate to collect our cost data prospectively, which increases the validity and reliability. And also we had extensive sessions how to collect this cost data. Typically, most cost assessments are done retrospectively, even in trials. So that was one of our major advantages in this study. And our costing methods and tools were aligned with the recommendations of the US panel on cost effectiveness in health and medicine. That way, we believe that we ended up with more reliable and valid cost estimates. And microcosting is specifically recommended for new interventions where no previous estimates are available. And by separating our programmatic costs from research costs, we also believe that we managed to give a realistic representation of resource requirements in real life settings. The limitations included basically our intervention was delivered in a school setting in 3 districts of Uganda. Therefore, the results may not be generalizable if there's a change in intervention delivery modality, for instance, a different intervention setting, or intervention is replicated elsewhere in Uganda or in another Sub-Saharan African country. The cost analysis is performed in a research setting. We did our due diligence again to separate research and programmatic costs, and it is possible that there might be over or underestimation of costs in some categories. For instance, monitoring and evaluation and quality assurance efforts are much stronger in research studies, so this might have introduced some bias. At the same time, we had training costs, which would be spread over a larger denominator if the the intervention is delivered to a larger population, and there might be some changes in different intervention settings and intervention populations. Lastly, measurement of the last point on the limitations is that William, if you can go back just one slide. Yeah. Measurement of personnel time heavily relied on self-observation by key program staff. This facilitated a reduction in burden on staff, but also this introduces a little bit of bias, and this is important when you are trying to match resource use to key specific activities of the project. We have received, or we have interviewed multiple staff members in their roles to be able to understand the human resource requirement that went into the delivery of the intervention. Next slide, please. To conclude, most child mental health evidence-based practices can be transported effectively from high resource to low resource settings. We have strong evidence on that. This study and other studies in Ghana and Kenya have been building this evidence base. We have the first microposting analysis for the MFG family strengthening intervention in a resource constrained environment. What we have found out is that compared to existing family-based interventions, we have seen a much lower cost per participant. However, the published literature is very thin, and we look forward to seeing the results of other studies to be able to understand whether it is possible to have more efficiencies in intervention delivery or just for comparison purposes. So we urge more costing and cost effectiveness studies to be part of these large scale evaluations. Usually, resource constraints, even in research environments, get in the way of producing this evidence base in a quality manner. Interventions aimed at improving child behavioral health have a dose response relationship with outcomes. More intensive programs also require more resources. However, it's very clear the economic return to these programs by reducing future health problems, delinquency, school performance, and all of that. So our next step is to combine our effectiveness results with these costing results and produce cost effectiveness estimates to show the basically the economic value of this intervention. And I'll stop here. Thank you very much. This is our research team in one of the schools, and I'd like to acknowledge all my colleagues who have made this possible, this costing study possible. Thank you.
All right, thank you so much to our lovely panel. We have about 17 minutes before we take our break, so I welcome questions. The chat is open. There are a few questions in the chat already, and I will I think, Avin, you can ask the question directly if you are still on. Dr. Avin, do you want to ask your question directly?
Yes, I am. The question I had was, I mean, we're just curious to see the higher rates of disruptive behavior disorders among girl children versus male children. And I was just wondering if there was a cultural explanation for that.
Yeah, so William, I think it was on your slide. So could you say something about that?
Thank you so much, Dr. Avin, and thank you so much, everyone tuning in. One of the things I didn't talk about, Dr. Avin, is that although we have those slightly different numbers, those numbers are not statistically different from each other. So one of the things I could think of in terms of cultural, understanding of the context is ideally we would expect boys to have more behavior problems. But one of the things that we have in our sample, we have slightly more girls than boys. But all these numbers, I have to be mindful that they are not different in any meaningful way. So they are slightly higher, but not and also looking at other studies in the area, I know there are several studies that have been done around Uganda in clinical settings. Those differences are not that significant as well.
All right. Thank you so much, William, for clarifying that, the numbers are there, but they are not statistically significant. But of course, it's important for us to think about, is there clinical significance then? Statistically, it may not, but is there something culturally why we see some of those numbers like that? There is another question. I don't know who this is, but it comes from Tekino Pavio. And they just wanted to know, maybe from Josephine and Joshua, the adjustments that were made as a result of COVID-19, did they affect the community in any way? Because they say, how was the community affected? The community that you were interacting with as you made those adjustments to adjust to COVID-19 lockdowns? I hope that's the question, that's how it has been framed. So Joshua, do you want to take that on, or Josephine?
Yeah, thank you. Yes, the community was affected at first because we had to stop the interaction between the participants and the study team. That's we were delivering when COVID-19 came and went to a lockdown in Uganda. We were delivering the multiple family group intervention in some of the schools. So we had to stop the delivery. Then we resumed afterwards, after like 2 or 3 months. So we had a challenge of the parents or the children connecting where we stopped and where we started from, the connecting. So we had to get to give a good recap of the previous sessions we had covered, so that we can continue with the new sessions we had to complete. Yeah, then it was also a challenge on our side. We had never used telephone interviews when collecting data, but we had a great training from the PIs, that is Dr. Fred, and I think the feedback we got from the participants, they also, some of them enjoyed it because they were free when they were answering the questions compared to when it was face-to-face interviews. So it was, yes, the communities were affected, but also the study was also affected in some way or the other.
Yeah, just to add to what Joshua indicated, we had to adjust the operations very fast. And when Joshua talks about using telephone interviews, it doesn't mean that for children or families which didn't have a phone, that they were left out. No. So what we had to do as an operation was to purchase over 70, almost 70 telephone sets. And then, so we would go to the community to avoid contact, would give the participant the phone in a polythene bag. They would get it, and then someone would call from the office to make sure that at least there's no direct contact. So that's how we did it in terms of using telephone. So whether a participant had a phone or they didn't have a phone, they were able to be interviewed and they were able to be worked with. So that was extremely helpful. I just wanted to add, because I know that people will wonder, does it mean that children and families which didn't have a phone were left out? They were not. We took care of them, but of course the expense was too much to us, but it was kind of cost neutral in that Fred didn't have to travel to Uganda to be able to, to again engage with the teams. We're able to move some of those travel resources that would have gotten us either to Uganda or to the field, the fuel and all that, into acquiring those funds. That's how we did it. We didn't have any extra funding from NIH for that. Then there is a question in the Dr. Yesim, it goes to you. It comes from Dr. Manasi, who is one of the investigators on the study. And Dr. Manasi is wondering that how do you do costing on a group intervention platform? And the benefits tend to accrue to the parents and community in the intervention. I think, to read the exact question says, I have a question on costing part. How do we account for the group as an intervention platform and benefits that accrue to the parents or community in the intervention? So I know that you haven't yet connected, you haven't done the cost benefit per se, you have given us the costing. And I think the second part of it will come in when you are looking at the cost benefit. But you are the economist on the study, I'll let you address that. And I think, yeah, so address that. And she has a follow-up question. Are there ways of reducing the cost to make those more attractive?
So on the first part, certainly there are benefits beyond the children participating to other members of the household. But in a costing study, I'd like to separate these two parts. As Dr. Fred said, effectiveness is different than the costing. For the costing, basically everything that has been, and all resources that has been used to deliver the intervention have been counted for. So all the family participation incentives and all accommodations that have been made to deliver MFG intervention in a family group setting, in schools, all these resources were included. So that's the cost part. Now, in our study, the intervention effectiveness was captured at the child level using these measures on their behavioral outcomes. So that enables us to combine that effectiveness results with the costing results to give, from that, intervention effectiveness perspective, whether it's an efficient use of resources. So if there are other measures that are part of the study to understand the impacts on let's say, family relationships, and I'm not the expert over there, but if we can measure those things, it is possible to use our costing results to be able to understand whether this intervention from an economic point of view makes sense to improve those outcomes as well. And our work doesn't end there. We need to understand what is willingness to pay in our environment. How does it compare to other interventions targeting the same outcomes? And, from an efficiency point of view, so we would compare it to other interventions with targeting the same health outcomes. So this is how we kind of set it up, but we did not exclude, it's not only child-based resources. We have basically included all the resource use in a multiple family environment to deliver this intervention to the children and, and to their families. I hope this answered the question. There was a second part, how to make it attractive.
Her question was, how can you reduce on the cost to make it more attractive?
That comes with the scale up. So we are in a research study. We had a target population to deliver. What we would expect is that these intervention costs, and if they are spread over a larger denominator, meaning that the reach of the intervention is larger, then we will experience lower costs per participant. However, the capacity to deliver the intervention is up to a point. So if you go beyond the target population, then your costs, a threshold will be reached, meaning that, you know, how many community health workers you have to deliver the intervention, they've been trained, and, you know, you can maximize that capacity. But if you reach beyond that target population where you need to train more community health workers, then we are talking about a proportional increase in your costs, and that's where the scale up comes into place. So if you exhaust your capacity, then, you know, your costs are again increase, and then you will again see some reduction as you reach, you know, that capacity. I hope this answered the question.
Yeah, excellent. Thank you so much. We have about 5 minutes, and within those 5 minutes, we have a few questions. I will also ask a question to each one of you, but there's a question from the mayor of Masaka. There was a question from our other colleague who is also Koi in Ghana, who wanted to find out from Joshua, how did you deal with young people who didn't have families which didn't have mobile phones? But I addressed that. I think I addressed that in my response. So Dr. Abdallah, I hope my answer regarding that, you know, this was a shared resource. We had to cut costs somewhere else for us to acquire phones. That's how we addressed that. But the question from the mayor of Masaka goes to Josephine and probably to all of us. I don't know whether Dean Mary is still here, but all of us. And the mayor of the mayor of Masaka has worked with us for the last, you know, almost 5-7 years, and knows this study very well. Is wondering whether, in reference to the letter that Josephine shared, whether the program will continue within the community, and so that it can eventually have a multiplier effect. And so, Mr. Mayor, if I may address that, I think that's an excellent question. But that's always the good thing about research. And I'm glad that we have a mayor attending from Masaka. So ours as researchers is to test out the evidence, to present the evidence, and to be able to I don't want to use the word market, because we are really not advocates, we are scientists, to bring the evidence to you and then try to figure out how do you take this to scale. And that's why we are costing it, Mr. Mayor, so that we can know. You can say, based on your budget for the city of Masaka or the greater Masaka, this is what you can do. These are the kinds of partners that we can bring in to partner with. So it's our prayer and hope that this can be taken to scale. And, you know, as a research group, we can definitely remain as consultants and as partners. But, you know, when the study comes to an end at 5 years, unfortunately, we'll have to end at 5 years, and then we'll have to pass this on to the community. I hope that addresses your question, because then at the end of the day, that's why we always engage policymakers like you, and we are glad that you are here, so that you can really hear the evidence and really see what the science speaks to, you know, introducing and implementing family-based interventions on the lives of young people, on the lives of those ones who go to school, and on the lives of families. And hopefully this will be part of maybe a byline in your budget that you can think about, how do you implement this very low-hanging fruit as far as I'm concerned. So that addresses the mayor's question. And then I hope, Mr. Mayor, I addressed your question. Then there's a question which came in via YouTube, but also via the chat. And they used the, I think I know what SUD and OUD mean, but I don't want to over speculate, because, you know, abbreviations are always hard. So I see William nodding his head. So hopefully what I know is what you know, William. Do you want to address that question on how, you know, the trends during the pandemic? But I just want to, as you address this question, I want people to also realize and know that unfortunately, or fortunately, either way you want to take it, we couldn't add COVID-19 related questions to our study because of the constraint you always have with the Data Safety and Monitoring Board, which of course meets so often during the year. And this is at the NIH level, and you can't add any new questions unless they get approved. And of course, you know, no one anticipated COVID, so we didn't have those questions ahead of time. And by the time they met, we were not ready. And by the time they were probably ready for us, we are already getting out of the field. But I'll let William take a shot at that, since you can also read the chat.
Yeah, thank you so much, Dr. Fred, and thank you so much for the person who asked the question. I do appreciate your concern about substance use disorders. That's my best guess of the abbreviations here. But unfortunately, as Dr. Fred indicated, we did not capture this data because, pre-pandemic, our primary aims were really about behavior challenges. So, and then as the pandemic came, we made, the possible changes we could for our populations, but as Dr. Fred indicated, we were unable to add these questions. However, I can add that in our other studies, we have looked at specifically substance use disorders among adolescents, and the trends have, surprisingly, the trends have been very low for our sample. We have looked at this among HIV positive adolescents living with HIV, and the trends have been very, very minimal. So we don't have specific data on this for this particular study.
Thank you so much, William. And I will ask one other question, and then we will wrap this up. We are just on time. The other question comes again from Abdara, and I know Josephine, you have these numbers handy. What is the attrition rate across the three arms, and which arm had the highest attrition rate?
Yeah, thank you so much, Dr. Fred. It is well displayed on the screen, and it so happens that according to the retention rate, one of our intervention group, which is actually led by the parent peers, had the lowest retention rate. And we are surprised, but of course, not really so much that these live within the community, but it's so great that at least one of our intervention arm as well, which is led by the community health workers, is really doing well with the retention rates. So I think it's well displayed. Dr. Abdullah, I think she's the one who asked, and you can easily tell the differences.
So we have a total sample retention at almost 93%, 93%, which is very high for a longitudinal study over a period of time. And then we have a retention rate in contract 97, at MFG by peer parents at almost 89.2, and the one for community health care workers at 93%. So thank you so much, Josephine. So I want to thank each one of you on the panel, and I want to ask each one of you a question, but probably I'll ask Rachel, since people didn't ask you a question, but I'll ask you a question. So Rachel, if you can think about redesigning this study, or think about the measures that we used as you were going through the data, how would you have changed the measurement? Or is this okay? And should we be happy the way, because you were not there when we were designing the study, you are coming in as a strong data analyst and you are looking at this data. What did you find to be the strength, and what were the weaknesses? And then I'll ask Dr. Yesim also a question. For the cost effectiveness component, what could we have done better? Is there something that, as you are working with a team in the field, that you wished, oh, I wish they had done this. I wish they had done this. I know this is being captured prospectively, but is there something that we should be mindful of? So those are the two questions. I'll stop there, because I want to be mindful of people's time.
Thank you so much. So I know for this study, we kind of screened children for disruptive behavioral disorders in order to, see which ones got the intervention. So I would have hoped that, everyone could have gotten the intervention, because it seemed to be positive in terms of reducing other outcomes as well. So for future analysis, we plan to also look at how the intervention impacts mental health outcomes. So, looking at depression, self-esteem, those kind of things. So yeah, that's one of the approaches that I would take.
Right, thank you so much. And Dr. Yesim?
Dr. Fred, I think on my wish list is when an intervention is being adopted and transported so successfully into a different setting, I think it would be very useful and helpful to be able to capture the costs of adaptation of that intervention. I know that the group worked very hard in a previous study, part of a previous study, to adapt the intervention to the population setting. And I know that it is to our intervention setting. And I know that it is research activity, but however, the costs of that kind of adaptation does inform us, at least other intervention trials, but also there's some of it always goes on in the field, in real life settings. So that adaptation part, if we could have captured those costs, then we would have the setup, adaptation and setup and then, you know, we went in with planning, delivery and monitoring and evaluation, which is an incredible advantage prospectively doing this on the ground as the intervention was delivered, but I would have loved to capture also the adaptation costs at the very beginning.
All right, thank you so much. I think William will feel neglected. I will just ask him a question as our newest doctor coming out. Mr. William, if you were to write a supplement, I mean, we have lots of young scholars who are listening, and we do capacity building also through SMART. What kind of question for you, having used the data, would you want to see asked if you were to do a supplement on Smart Africa or given the hubs?
Thank you so much, Dr. Fred. On the top of my head, one of my wish, you know, one of my quick question I would love really to engage in is to really go into some qualitative work to understand how do communities even understand oppositional defiant disorder. We ask a set of questions, but from, you know, we have had parents talk about kids being stubborn, but what does that exactly mean within the local context? What does being stubborn mean to a parent? What behaviors do children engage in that parents consider to be stubborn? So really trying to qualitatively understand where, you know, how parents perceive these behaviors and what they consider to be dysfunction on their own environment and context.
All right, with that, I want to thank each one of you for having been part of the panel. I want to thank our audience, and I want to invite back Dr. Anne Mbayo and Dr. Proskovia Nabunya, who are the masters of ceremony for today, to take over from here. Again, thank you so much all. Stay tuned for our publications. We already have Dr.